Hello, I'm Mally Shansfeld, Managing Editor of Orthodontic Practice US, a MedMark publication. Welcome to a live discussion and question and answer with Dr. Ed Lin. Our webinar today will be on indirect bonding trays from suresmile elemetrix. Before we get started, I would like to invite viewers to use your question box in your control panel to ask any questions. Your questions will be answered at the end of the session. Now, I'm pleased to introduce our guest for today, Dr. Ed Lin. Dr. Lin has been in practice since 1999. He has lectured at orthodontic residency programs across the country and has authored numerous articles appearing in dental and orthodontic journals, one of them being our Orthodontic Practice US magazine, where he also serves on the editorial board. Dr. Lin, we turn the webinar over to you to learn more about the topic for today, indirect bonding trays.
Thank you very much, Molly. Good morning, everybody. So I'm looking forward to sharing with all of you our practice's experience with suresmile's indirect bonding system over almost the past year. We started with them doing this in alpha testing, then we went to beta testing, and now it's commercially available to everybody. And we're actually going through a big paradigm shift in our practice right now, and we've actually got a big training session set up for the 4th of October. We're really going to focus on training some of the staff to take some of these responsibilities away from the doctors for the digital setups. And as we transition, I don't know if we'll ever go 100% suresmile indirect bonding, but we want to make it the great majority of our practices indirect bonding setups. So let's get started with the presentation here. And all of you have my email address here at the bottom. And this is something that we are actually going to be using in all three of our practices, 2 at Orthodontic Specialists in Green Bay and 1 at Apple Creek Orthodontics in Appleton. All right, so I am a firm believer in history because I think that you need to go back and evaluate how you've done things and what you've done well, what mistakes you have made, and the best way to learn, as we all know, is to learn from your own mistakes. And one of the things I think I chuckle about way back when I was doing my residency at Northwestern University in Chicago from 1997 to 1999 is this is actually how we started doing our indirect bonding. We put adhesive on the back of the bracket, placed the bracket and adhesive onto the stone model with separating medium, and then we'd heat up some sugar daddy and stick it on there and let it dry, let it cool off, and then we'd later on down the road would fabricate our indirect bonding tray setup. All right, and now look at where things have gone. So those of us who have all been involved with indirect bonding probably know what these are. These are the black boxes, all right, to keep light out. Okay, and this actually just happened this past spring. One of my lab techs dropped off 2 of these black boxes on my desk right at the end of the day. It was right around 5 o'clock, just getting ready to finish up the clinic. And you never complain about something like this because there's 10 full cases starting up here because that's a ton of production. But the issue is, I also know there's a ton of work that I have to get onto doing this because you want the adhesive to start setting up, getting tacky on the models. So I probably here have at least an hour, maybe an hour and a half of work to get all these models done here. All right, so we started dabbling with true indirect bonding systems in our practice back in 1999, and back then we actually used the Ormco adhesive with Part A, Part B, one on tooth, one on the bracket, and we used these PVS trays. Light body on the inside around the bracket so we could peel them off, and then the heavy body over the top. The issue with these is you really never knew if you fully had the tray seated. And, I always remember because I used to do all these myself in the beginning, you peel these off and just kind of pray. Keep your fingers crossed and pray that everything's on in the correct position. And when you find out that it is, you have a big sigh of relief. All right, so one of the disadvantages there, obviously, was you couldn't see what was actually going on there. Well, as we continued our transition, we actually started making the switch over to Sandi technique, and you see the 3M over here. And again, Part A, Part B, one on the bracket, one on the base. We started actually micro-etching, proframe first actually, then micro-etching, using the tooth dryer before we acid etched, and then placing the adhesive on the bracket and the enamel. All right, again, one of the issues here was we could not see what was actually taking place because we were still using the heavy body PVS tray. So in 2005, we started making a big switch over to silicones types of materials with Memosil. All right, and Memosil was a clear material, so you could actually see if the tray was seated. We would back it up with a hard body shell, suck down hard body shell, And this is actually what our system looked like with the light body over the brackets. Obviously we're doing both lingual as well as labial. And this here is the, oops, I'm sorry, is actually what the tray actually looked like. And we would have our labs package it up and be ready to bring up to the clinic when the patients were there. All right. But again, we could not light cure through these because of the light body PBS material, which was blue, not clear. So we actually, 2012, started making a transition into light curing system, and we switched over to actually Enaluma in combination with Memicil with the hard body. Okay, all other systems were the same, but the advantage here was we could shine a light curing unit through the tray and cure the bracket, through there. So our protocol back then was we cure 6 seconds, and you can see here. 6 seconds on each tooth and bracket. We peel everything off, and then we actually go back over and cure it for another 3 seconds on each tooth and bracket there. All right, and we actually were using this opal veil light, which is a really great light. Has got a wide head, and we really dispersed the light out everywhere. The issue with the veil light was there was like a 1 second delay in between each 3 second cure, so it was a little bit of a lag time. All right, so what are the benefits of traditional indirect bonding systems, especially that we have used since 1999 in our practice? Well, claims have been made that it's more accurate bracket placement since the brackets are placed on a model. Doctor can perform the final check for bracket placement at his or her own leisure, not under a set clinical schedule, which is true. We could reduce doctor clinical chair time as the assistants can place the indirect bonding trays, and without a doubt, that is a key part of any indirect bonding system. If the assistants are doing that, we can be seeing other patients, we can be doing other things, suresmile setups, etc., consultations, etc. All right, improve patient comfort due to decreased treatment time that the patient is in cheek retractors, and that is without a doubt true as well. Okay, so what are some of the deficiencies of traditional indirect bonding systems? One, there's an increased cost. Actually, I had done a cost analysis in our practice, not counting doctor time with checking the brackets, but just for once we sent the impression material down to the lab taking it over with pouring up the models, placing the separate meeting on, placing the brackets on, and then setting up the doctor. No doctor time is involved with the cost. The doctor checking the brackets, then setting that down in the lab, and then having the lab fabricate the indirect bonding trays. And we timed this. We figured that it came out to about $30 per upper and lower. So that was very cost effective. But there's still doctor time involved in that. Traditional labs are typically somewhere in the range of $200. They have different ways of billing, but I'm just saying it's around $200 for traditional indirect bonding trays. All right. There's also potential distortion in impressions, could obviously lead to inaccurate models. There could be distortion in the pour up of the indirect bonding models with blebs or bubbles where you get voids in the model itself. Short clinical crowns are not ideal for indirect bonding and need to be direct bonded, especially with mandibular dentition. Obviously, you have to keep the bracket more gingival so they can keep it out of inner arch interferences there. Brackets can be bumped prior to curing on the indirect bonding model, leading to inaccurate bracket placement. And seating of the indirect bonding trays is technique sensitive. We probably have about 15 assistants in all of our practice, and without a doubt, that is definitely one of the challenges is we're trying to train some of these younger assistants on the indirect bonding systems, is overseating or underseating. And if you overseat, you get an angled bracket. If you underseat, you actually are kind of stuck. You have to take the brackets off because they're not on. They're going to fail anyways, and you got to direct bond. So that can be frustrating. All right. So now we are going to talk about the suresmile indirect bonding system. And the great thing here is you can actually use any intraoral scanner. However, these 5 scanners, the suresmile Aura Scanner 2, the iTero, all the iTeros, including the Element, are now certified. 3M's True Definition Scanner, the Carestream CS3500 intraoral scanner. We actually have the Trios 3 in our practice, so I'm a little bit biased. I'm going to admit that. We have one at each practice, but I'm just going to tell you, I personally feel this is the best intraoral scanner on the market. We can now scan, I'm going to say on average, without brackets, about 1 minute. Upper and lower arches. It takes about 10 seconds to do a bite. All right, and there's a little bit of delay time, so we can get all that stuff done probably around 2 minutes with everything. All right, our fastest without bracket scan actually was 46 seconds by Angie, our clinical director. with brackets on, we're scanning probably on average about 2.5 minutes. All right. So, I only put these 5 intraoral scanners up on the slide here because if you're starting off at least looking at SureSmile, you might want to consider getting one of these just because you never know it might transition into wires and brackets in the future. All right, so let's look at a patient here. So this is my patient, Melissa. She actually, you can see with the arrow, she's got an upper right E present here. Her records were done in September 2015. All right. If you look here, she actually didn't get started with her treatment until April of 2016. All right. I'm just going to show you a little demo here of how you can place an order here. All right. This is actually done in double speed just to try and save time because I'm limited with time with a 45-minute webinar here. Whoops. Go back here. All right. So this is all cloud-based. And you just go to New, you place Indirect Bonding Simulation. It'll bring it up, bracket. You look here, there's many different types of bracket designs that you can order. We are American Empower stainless steel and clear bracket. You can set prescription heights as well. And I have set up my own vertical prescription heights. And that's customizable to anybody. And as we all know, we all like to do it differently. You can see here the setups here. All right, so this is actually the, watch right here. I'm moving these brackets down because these are showing you gingival penetration. It starts off with green, then yellow, then red. All right, it's going to move more occlusal here. Just watch this. There you go. And, this is a key factor here because we can actually position some of these brackets a little bit more gingivally, all right, because the SureSmile software will find the best two-point contact. All right. I want you to focus right here on the upper right 5. Remember, that's where the upper right E was present there. You can see the gingival margin, the gingival tissue is covering part of the bracket there. All right. So now we're actually I'm going to give you a little demo of how we can actually set brackets up into positions. You'll see here we can do occlusal gingival has already been set by my prescriptions. I changed that a little bit to get it more occlusal, to get away from the gingival tissue. We can control things mesial-distally as well as annulation mesial and distally with the long axis of the tooth here. All right, and this box here is where I live in, and this is just my way of doing things. And as you see, I'm moving that a little bit more distal, a little bit more mesial angulation. I'm going back and forth, toggling. The software has some preset views so that when you click from one to angle another angle, it shows you ideally what position you should be in. So it's very efficient. A little bit of mesial angulation there. Okay, so that's just a quick little demo. I'm not going to do every single one, but I think all of you get the gist there. All right, so if you actually looked at what actually happened here, the software also will allow certain gingival penetrations, like here and here and here, also here with the upper right 6 and 7. But the upper right 5, the gingival penetration was too great. And so as a result, I had to take that bracket off. So it's very easy. You just can't click and remove a bracket button. And the reason for that is because the 3D printed indirect bonding trays of SureSmile need to be able to grab onto the bracket wings. And so the software had calculated that there just was not enough bracket for us to be able to grab onto that bracket precisely so we would get a good seating and good position of the bracket. All right, so one bracket direct bonding, not a big deal. And you can see here, this is the bracket that I had to direct bond. Now here, there's a little terminology here. I'm just going to talk a little bit of wires and brackets. This is called the SureSmile Fast Track. And what this means is the day we do the indirect bonding, we're actually doing the SureSmile ICAT scan of the patient. Okay, and I typically would start this patient off, I think like a 16 round wire, maybe a 16 squared wire. I got the slide up later. But then 6 weeks later, they are going to be getting their actual SureSmile wires. Okay, and you can see here what's changed here. With the brackets on. Okay, and I direct bonded the bracket here. And then this is a progress photo, August, so less than let's say 3.5 months later. I mean, just look at this. The case is actually almost completed. I got a little space close up here, but the wire is still expressing itself. I usually let my SureSmile wires work for about minimum 4 months, usually 5 months, okay, somewhere in that ballpark. All right, and this is just showing, this is the day of the full bonding fast track. I actually started off with 16 squared wires. We actually are 018 appliance, just so you're aware of that. 6 weeks later, we jumped her from 16 squared straight wire, copper nitride wires, into the SureSmile 1725 copper nitride wires. And you can see I also started some elastics here. In August, when we got those photos, we stopped the elastic, just ran a little change to close up that space that I showed all of you to distal upright 2. You know, I know I have her coming back in October again. We're going to be doing some virtual wire bends to modify things a little bit, and then 3 weeks later we'll put in the finishing SureSmile wire. So realistically, I'll probably have it done maybe earliest sometime towards the end of December, maybe latest middle of January. So, you know, to start the date, you know, that's, what is that? It's 8 or 9 months of treatment time. All right? Upper 77, lower 77. So this was our current traditional indirect bonding tray. And we all know what indirect custom basing is. You place the adhesive on the model, you place the brackets on there, you make sure you're pushing hard because you want to get the adhesive to flow into the mesh of the pad. You clean up the extra adhesive, and then you put it into a triad curing unit, and you cure all the brackets, and then you can see the Memosil with our Emaluma, and then there's a hard shell that goes over the top of that too as well. All right. Now I'm going to talk to you about a little different concept which I've thought about since we've been doing the SureSmile indirect bonding system, is direct custom basing, because we no longer need to do that indirect bonding anymore. This is living in the digital world. So what I want to focus on here are this young lady's upper sixes. She's got kind of like a rhomboidal oblique crown anatomy here. And you know, where do you put this bracket? Because if I put the bracket right here, I mean, it's going to rotate things. So how do I figure out exactly where this is going to move the tooth to? I think these are all things that we think about as we're placing brackets, whether it's directly or indirectly. But you know, the cool thing is in the SureSmile's indirect bonding system, we actually have a digital model, diagnostic model is what it's called. And we can quickly try and manipulate those teeth in the software, which is what I did here. Blue is where the actual position is, and white is where I'm moving the teeth to. And I can see upper left 6, I'm putting 15 degrees of mesial rotation on the tooth. So that's what the bracket position is telling me to do. Here is 6 degrees of mesial rotation. All right. And so now I'm going to show another video here. And what this does is this is just it's a class 1 simulation, very easy here. Watch me click on this molar class 1 box. It's pretty good. I think there's some improvements that could be made here, but you know, look at what has happened here. Just a straight wire simulation is all this is. But it gives me a good idea of where that bracket needs to be, so that's what I did on the model that I showed you previously. And now let's look here, and this is where the bracket needs to be held. So now, whether you live in the indirect world or the direct world, how do you position that bracket accurately on a oblique or rhomboidal crown like that and hold it there precisely? It's very difficult. You know, in the past, you know, if you can even figure it out actually, but in the past there were times when some of these teeth I would go grab a curing light and just cure that one tooth, all right, before putting it black in black box, just so hopefully it's staying there. So my concept now that I'm presenting to you is direct custom basing. So what we're doing now is we use Transbond. We placed adhesive onto the bracket pad, and so this is with the actual indirect bonding tray, the 3D printed indirect bonding tray, SureSmile. But then we're going to be seating this onto the tooth, the patient's teeth there, and then curing it there. And then you got to make sure you have enough adhesive there, so you don't have any type of void there. Okay. So if you look here and you look here at the upper left 6, you can tell that without a doubt there's more adhesive in that area there, and there's more adhesive here on the upper right 6 too as well. So you know, that's the advantage of this SureSmile indirect bonding system, is the digital bracket is positioned on a digital model, on a digital tooth. The digital 3D printed tray will hold it very precisely there for us there, and while we're actually directly curing this actually on the patient's teeth there. So I believe this would lead to more precision, greater precision. And you know, as you also, this was a class 2 division 2 subdivision right, full class 2 on this side here. And you know, just showing you, this is just photos I took back in July, so just a couple months ago. But I distalized the upper right 7. I had a tad, you can actually see where it was. This is the day I took the tad out, repositioned it more posteriorly, and now I'm running a retraction hook with the Nitai retraction string, as well as with chain, to bring everything back en masse retraction. Okay, so this is actually the SureSmile's indirect bonding packaging as well as their trays. It's a small box, you know, very different than, remember those big boxes from Invisalign way back in the old days. Very small box, so it's very space-wise, minimal space requirements. Everything is labeled very clearly on the front of the box here, so we can actually see that. And if you ever get a chance to get a feel for these things, They've got some flexibility to it, but they're very rigid. So when you know they're seated, they are seated on there, and they hold that bracket very precisely there. All right. So this is our suresmile indirect bonding setup. Things haven't changed much. We still have the tooth dryer. We're still Profi before we etch. And then we did switch lights, though, we purchased these through American. They're the Acutech Blu-ray. They got a smaller tip. I believe that this next slide will show you the difference here. But we went away from the Velo lights because the heads were so big. But with suresmile's 3D printed indirect bonding trays, you can actually get in between the brackets, and you can actually, with this lighter, smaller head, we can get there and directly cure onto the enamel as well as the bracket pad. And so we just get immediate curing right off the bat before we even try to remove the trays. And I've got a slide to show you that a little bit later here. Okay, so this is what we do. We have before the patient comes to share, they basically prepare the tray. So they clean each bracket pad with alcohol and they let it dry. You apply bracket adhesive to each pad. I already said we use Transbond. We use Opal Seal to push the adhesive into the pad mesh, and that's illustrated here. Just a tiny little bit of the liquid from Opal Seal, and just gently depress it into the pad there. All right, and then everything's put in underneath a black box, excuse me. All right, and then we Profi the teeth. We rinse and dry well. We etch for 30 seconds on each tooth. Rinse and dry well again. You want to see that chalky appearance. All right, then we take the tooth dryer. You know, the research has shown using the tooth dryer actually increases bond strength by approximately 30%. So again, the key step, I think, pay attention to details to minimize bracket failure. We then use the Opal Seal, you know, the syringe with the cotton tip of the applicator, and we just apply a thin seal. You can see, we tell the assistants, make certain you look where the digital bracket is on the model, so they have that all pulled up at the chair side. And then we blow just a little bit of thin air light air to thin out the Opal Seal. Okay, it's a little bit of viscous material. And then we're ready to seat the trays. So we typically will try and do things all one arch at a time if we can, but as we all know, that doesn't always happen. You can actually, in suresmile software, you're able to segment the trays if you need to, if there's severely rotated teeth, or if there's a tooth that's not fully erupted as well. The software will tell you that. It's very simple, user-friendly. All right, so, but we try and do one full arch at a time. And the key things are to push labially and occlusal first, actually, then labial and buccally. All right, and you can see this is depicted here with the plugger. And then after we feel everything seated, before you cure, you take the Opal Seal syringe and just go around the bracket and you clean up the excess. So we really truly have very little excess. The only area we get a little bit of excess is on the incisal or occlusal, but that makes sense because we can't get access because that's where the indirect bonding tray is. All right, we use the, we call it the AO light, but it's the Acutech Blu-ray, but we actually use our Freedom Dollars through American to purchase these. So actually they're basically free through our annual bracket orders. And then we cure each bracket for 3 seconds on the labial buccal surface, and another 3 seconds on the gingival surface. And once the tray is removed, we cure each bracket again for another 3 seconds, just to be sure we got a good cure. All right, tray removal. So what we want to do is, once we know that things are cured, we have these lingual as well as these labial splines. So we just use here it shows a scaler, but I think now we use wine guards. We basically just kind of peel it off. They used to break before, the splines would break, and the reason they're there is just to give us a little rigidity of being able to make certain the trays are seated correctly. But now suresmile has reinforced these, so they come off pretty easily now. And then we take the scaler to basically peel, and I think we've got another slide right here. Yeah. No, actually we don't. We take the scaler and we just kind of peel right there from the gingival and just kind of peel it right off. Okay. Here is an example actually of a segmented tray. I'm sorry, I actually just put this in just prior to the webinar, but just to show you how one segmented here because of the rotation, and then we've got another one here too as well. And obviously with the maxillary, we were able to do it all full segmented. But here's the scaler removing by going from gingival to occlusal, removing the indirect bonding tray. And then here are photos of the completed upper and lower arches. Okay, and then this is just showing the digital setup with the true setup from the occlusal. All right, and again, just blow up of the segmented trays here with the mandibular dentition. And then this was here, the example of the digital setup with what actually happened here. And actually, I want to go back here just for a second here. We actually, and this is a patient that we actually treated last year. This is actually Jessica, one of our assistants. But we actually physically segmented the trays ourselves here on the 6s here and the 7 over here. Or these are actually both 7s, excuse me. Because there's a little bounce there. So you can actually, if you don't feel comfortable with the tray and with what's happening there, you can actually cut things off, and that will eliminate the possibility of bracket positioning error. And that's why I showed that, because the bracket was not actually in the indirect tray. We actually ended up direct bonding these 3 teeth here. All right. This is January this year, just kind of showing Jessica's progress. You saw we actually used a TAD down here to protract everything here forward. She's going to plan on getting a dental implant here later on down the road. And so what we actually did last year with suresmile is we were evaluating the bracket positions. We actually submitted to them, after we placed the brackets onto the teeth using their indirect bonding trays, we actually intraoral scanned, I believe it was 9 patients. And then we sent all that intraoral scanning data to suresmile, and they evaluated the results, compare where the actual brackets ended up on the teeth in comparison to the actual digital setup. And they measured things in the X, Y, Z axis. X is mesial distal, Y buccal lingual, Z is occlusal gingival. They also measured things in translational error and rotational error too as well. And if you look here at these measurements here on the screen, over here in translational, you're talking about millimeters. So they're measuring it to hundreds of millimeters, all right? And there's nothing that's big that stands out. Everything is 0.3, 0.2, maybe here 0.6, minus 0.6. All right, in rotational, this is measuring at a degree, but you're seeing under a degree, 1 degree, 2 degree, 2.87 at the most. So this is incredibly precise, and the results show that these more precise than what is currently available with traditional indirect bonding systems. And this is just showing where the bracket should be seated in the indirect bonding tray. And this is actually showing the white is actually seated in the tray. This is where it actually ended up, and it actually was not seated. So there was a little bit of error on this one posterior molar here. All right, and we are actually currently, I think there's a few other practices right now that are submitting the same type of data, and we actually just gave them 15 additional patients of ours where we placed the brackets on using suresmile's indirect bonding, 3D printed indirect bonding system, and then afterwards we intraoral scanned them with our 3-shape scanners, and now the scan time is so much easier. It's a much easier. It's really not much of a disruption for us anymore in the clinic in order to do that. And so Ben Kozad is on faculty at University of Houston, Texas. So I am not certain exactly when his results are going to come out, but I have asked him as soon as they come out to please forward them on to me. Okay, so what are now the benefits of suresmile's indirect bonding system here? All right, so more accurate bracket placement as a result of digital models created from an intraoral scan with digitally positioned brackets and a custom 3D printed indirect bonding tray. I think all of us in orthodontics recognize the advantages of intraoral scanning versus impressions, and then having to pour it up. There's just so many potential steps for error there. Now you have digital hard data, and that digital hard data, as long as you have a good scan, you just have to make sure you capture the frames. It's going to be more precise than we have anything that we've had currently to date with impressions. All right. The digital position brackets, I think I already showed you the video. We're doing this to 0.1 millimeter, 1 degree of accuracy. And the custom 3D printed indirect bonding trays, I think I've explained to you, they're rigid. They seat them. When they're there, that's where they're at. Okay. We can delegate the initial indirect bonding setup to a digital lab tech within the practice and can create a system for precise and quantifiable digital bracket placement that can be replicated efficiently and accurately. We are going through this paradigm shift in our practice right now. So we've actually just had the busiest summer of our practice careers for all the doctors. It was just crazy. So we really haven't had any time to really work with training the lab technicians. But we actually have a meeting set up on October 4th with all the doctors and the lab technicians to train them to be able to help do the initial setup first. But when you're doing this, when you're trying to train somebody, and I've trained somebody many, many times over the last 18 years now, how do you tell them where that bracket needs to be? 0.2 millimeters mesial, 2 degrees distal, 0.2 millimeters gingival, And there's some people that just couldn't get it in our practice, and there's some that could get it. And I call it having the eye. And there's some people that we tried to train them that just didn't work out. Others, they had the eye and they picked up really quickly. Well, now we can show them quantifiably in that box that I showed you, mesial distal, occlusal gingival. And the doctors can actually set the vertical positions very quickly. I showed you. You can just hit arrow button, hit the other 7 to 7 shift, or upper left 7 shift, upper right 7, and then that will do all of those teeth in one. You can move them 0.1, 0.2, 0.3, more occlusal or gingival, whatever you decide to do. It's super easy. All right. So this is something that we have set up on October 4th in our practice, and we are going to start changing that over to the digital lab techs now. We actually have digital lab techs in our practice now, and I currently have been doing about 12 per month myself, my hope is it's going to take a lot of work off the plate for me in the future. Okay, so the doctor can still perform the final check for bracket placement at his or her own leisure and not on a set clinical schedule anywhere through the cloud. And I think our lab techs are going to get these pretty darn close. If there's anything that even changes, going to be really, really minor. So it's going to save me time. No more black boxes. These black boxes, man, I have had to take them home. I've had to move them from office to office. I just don't need to do that anymore. I can't wait until I don't have to do that anymore. Less flash cleanup around the brackets. Without a doubt, it's easier. The only area of issues that we need to be concerned about is the occlusal or the incisal. Can Indirect bond short clinical crowns more precisely as we're creating a custom base with a bracket on the actual tooth and not on a stone model? On a stone model, you're stuck. I've talked to people, and I've done it myself, where you will take a column back carver and you'll carve a little bit away the stone model, but how precise is that? There's error there. Here, the software is finding the most precise 2-point contact, and you can set it down into that virtual gingiva if you want. Okay, it just can't be too far, but it can be down a little bit. And so we can now indirect bond subgingivally, and I showed you that with that first case that I presented. Reduce doctor clinical chair time as the assistant placed the indirect bonding trays. Yes, that's true, again, with all indirect bonding systems. Improve patient comfort due to decreased time that the patient uses in treatment factors. Again, true for all indirect bonding systems. Can light cure directly the brackets due to the 3D printed design of the trays? SureSmile's indirect bonding, 3D printed indirect bonding tray designs are the only ones that I know that can get you directly onto the enamel and to the bracket pad. So, when I look at the benefits of SureSmile's indirect bonding systems, all these points that I have highlighted in red, those are the benefits there, these 7 benefits here. The ones in blue are the same that were true with conventional indirect bonding. All right, and again, no more black boxes. All right. So if you are interested in learning more about the SureSmile's 3D printed indirect bonding system, Dr. Rohit Sachdeeva, who I consider to be one of my mentors, one of the founders and former clinical director of SureSmile, he wrote this phenomenal article for Orthodontic Practice US back in March and April of this past year. A very in-depth article. Most recently, at the end of last month, I actually just submitted this blog article reviewing all the different indirect bonding, 3D digital indirect bonding systems that are available. If any of you are interested, haven't seen it yet, just Google AAO Tech Blog 3D indirect bonding, and it'll come up very easily. All right. So just to finish things up here, this was a slide. This slide is on a summary of the Davos 2016 World Economic Forum. They hold us every 2 years in Davos, Switzerland, and I kind of follow this just because when I saw the theme of the convention, it was called the Fourth Industrial Revolution, and the whole conference was focused on artificial intelligence and robotics. All right, and I look at this need to embrace robot revolution, not fear it. Tech leaders say. I mean, I've been doing suresmile now for 12 and a half years, actually, believe it or not. And I remember, yeah, it's fearful, but I don't think it's fearful anymore for me. I mean, I think we really have embraced it, we've learned it, and I'm not going to say we've perfected it, but we have become pretty darn good at it, though, for the betterment of our patients in all aspects of wires and brackets, labial-lingual, suresmile aligners, and now 3D printed digital indirect bonding. All right, final couple slides. Your work is going to fill a large part of your life, and the only way to be truly satisfied is to do great work. The only way to do great work is to love what you do. If you haven't found it, keep looking, don't settle. As with all matters of the heart, you'll know when you find it. And I'm not certain if any of you know who said this, but the gentleman who said this is somebody who I think has made a significant impact in the entire world and all of our lives. And that gentleman was a genius by the name of Steve Jobs. All right? And actually, I just pre-ordered my iPhone 7 Plus today, so I'm excited about that. All right. So if any of you are interested on suresmile Universe, suresmile U is what they call it. They have this video. This is actually a full-length video of one of the patients that we indirect bonded using their system from start to finish, okay, in real time. All right, and if there are any questions, I would highly suggest that you call your local representative for more information or visit elemetrix.com. And this is for all the reps in the United States, Canada, Europe, Asia, and Australia, okay? And if you want to print screen this, please do so. All right, thank you very much, everybody, for your time and attention. I'm going to turn things back over to Molly now.
Thank you so much, Dr. Lin, for that very information-filled presentation. We're already getting questions in, so this is very exciting. Before I get to these questions and my questions, I again want to invite viewers to put their questions in the question box in your control panel if you have any while we're asking our questions. The first question that's come in is, how successful is subgingival bracket placement? And at this point, do you direct bond those brackets, or do you include them in the IDB tray?
If the software allows us to keep the bracket on a digital model for subgingival bracket placement, we keep it on there. If the software it basically gives you a red flag. It says you can't do it. So you basically just remove the bracket. It's just, like I said, it's just a little button, remove bracket, and it comes off. The bracket comes off. So then that tooth will have to be direct bonded. In regards to bracket failures, I mean, we have very little bracket failure. You know, this is still something new that we're training our assistants. Our more veteran assistants have become excellent at it. So I would tell you, very rarely do we ever have a bracket failure. Some of the newer ones, just like with anything, you gotta practice at it to get better. You know, so you may lose one, you may lose a couple, but that's the most. And we have recently, I would tell you, in the last two years, we probably have hired 7 assistants in our practice. So we've been growing. So you know, that's part of growth issues that you have to deal with.
Okay, next question. Does the straight wire simulation account for full expression of torque of the selected bracket?
You know, I'm going to tell you that I still think that it's not going to give you full expression. At least that's my perception of things. I think it's something that they're still working on improving. So I think that would be a better question to ask your suresmile representative, and maybe direct it to somebody like Phil Ghetto, their Chief Technology Officer.
Okay, and one more question. Are custom pads used on all brackets in IDB set up to simulate a straight wire finish?
Yes, they are. And I call it the direct custom basing, as I explained to you earlier in the presentation.
Okay, how does it usually end if you're using it as a straight wire treatment, not doing later planning with suresmile?
Well, I guess, you know, I'm a suresmile doctor, so I'm not going to tell you it never ever happens, but it doesn't happen very often throughout the year where, you know, I put on the brackets and then we're ready to do the suresmile scan, and I look and I say, I'm not going to do suresmile. I mean, if it happens, it's maybe like 2 or 3 times a year at the most. So, you know, I'm a true suresmile doctor. And the reason I say that is because there have been times when I've done that, and it happened to me recently, just this past year, where I didn't suresmile scan, and I looked back on it, and it took me longer to finish up the patient than if I would have just suresmile scanned the patient. I would have had the patient done probably like 4 months later, you know. And I should have done it, and I kicked myself because I had to see the patient more frequently because I'm bending beta titanium wires. So I'm not a straight wire guy. I'm a suresmile doctor. So this is just one bracket application philosophy for me in my practice, and then I transition to suresmile. Now, if it's something that you want to play with more with straight wire simulations, then you're going to have to spend the time with bracket positioning, running that straight wire simulation to see where it ends up. And I know that there are guys that are out there that are doing it, so I'm not one of them, so that's about as much as I can comment on that.
Okay. How do you limit flash or clean flash doing this suresmile IDB?
Well, you know, we always tell our assistants more is better than not enough because you don't want to have voids. So that, you know, I showed you the slides of them using the opal seal cotton applicator tip with a little bit of opal seal, packing that in there. You know, it's a little the liquid is a little viscous, so you know, but it gets the transbond to flow a little bit, and you want to make certain you have enough. So you got to make certain the transbond is enough, but not too much. And I think that's an experience issue, and we talk with the assistants about that after we do one of the indirect bondings, because if there's too much, you will have a ton of extra flash. But again, remember, they're going to take that opal seal cotton applicator tip, and they're going to go from the mesial, the gingival, and the distal, and they're going to clean all that up. So the majority of the flash is going to be on the incisal and the occlusal. Okay, so it's a lot less than conventional indirect bonding.
So many questions are flying in. Brackets are placed in the tray in the office, or do they come in the tray?
Great question. Brackets are placed in the office, and it's a little bit tricky in the beginning to get the feel for it. We actually have magnifying glasses. The girls in the lab are the ones who place the brackets into the trays. Again, we use Empower stainless steel and Empower clear, but that's clearly illustrated in the suresmile packaging, so you know, and we also obviously document it clearly in our patient charts. But you know, as long as you have the magnifying glass, when you seat it, you can see it, and you know that it's fully seated. And it only takes, you know, a couple seconds, maybe 3 seconds, to see the bracket there. Okay, once you learn how to do it, it's pretty simple.
Okay. How do you handle a bracket coming off mid-treatment? Do you direct bond that bracket?
Well, yes, we direct bond the bracket, and that's how we've always handled it, which are all of our suresmile cases. But in this, because you're living through the cloud, you'll have your user ID and password. You can always pull up the patient case, and you can look at where that bracket is positioned on the digital model, and that's what we actually have the assistants do for us. So before we come back to reposition brackets, they'll have that pulled up for us, and we can, you know, we're still orthodontists. We've got to figure out where to put things. So, you know, we'll have that pulled up. You know, if the occlusion looks good, the alignment of the tooth looks good, then my recommendation would just be to use whatever your wire you're in, and use that to reposition the bracket. If it's off a little bit, and you think, hey, the tooth is rotating a little bit, well, use that digital model with the digital bracket on it, and do your best to get it into the perfect position there. So that's how we handle it. And if you need to tweak it a little bit afterwards, you can do it conventionally by repositioning the bracket a little bit or putting a bend in the wire. In suresmile, usually when we do that, we will actually virtual wire bend it, meaning we just put a little rotation tip, whatever, up, down, and then we hit order, and then we have them come back and put that wire in 3 weeks later.
Okay. Do you have to click on something to allow you to alter the bracket off the tooth, like those molar rotations?
Yeah, you can live in the box, or you can click on the bracket. If you click on the bracket, it will highlight the bracket, and the bracket turns purple. And you can move it using arrow icons on the actual bracket itself, or you can move to the box and move it mesial-distally, or occlusal-gingivally, or angulate mesial-distal. So I live more in the box. That's just the way I do it. I know that there are some guys who prefer trying to grab onto the bracket and then moving the bracket itself.
Well, how are you isolating the tongue?
Excuse me, Mom. Go ahead.
How are you isolating the tongue?
Well, we just use cheek retractors and cotton rolls and slow speed suction. I mean, you can use. We used to use the NOLA. We used to have tons of NOLAs, but I think as our system's gotten, and we've been getting indirect bonding for, this is our 18th year, so we've gotten pretty good at it. So I think they've gotten really good with isolation controls. But NOLA or just use cotton rolls with cheek retractors.
Is there an initial fee for the software or just pay per case?
I believe that there is some cost involved, but I have no idea what that is with it getting training done. However, I do know what the actual cost of, and I think, and just before I move on to the actual cost of what the trays are, I think that the cost is pretty minimal. All right, and the training is pretty simple. I mean, the software, you just have to learn how to grab on the tooth, how to live in that box. I mean, it's not going to take a long time. I think any novice could learn how to do that very easily. So talk to your SureSmile rep. I think they can better answer the upfront cost. But for the actual trays itself, it's $45 for SureSmile to create the digital model for you to be able to move things around. That's called the diagnostic model. And that's for them to clean it all up, the intraoral scan and the segment the teeth, so you can move them. Very cost effective. Each arch costs $30 per arch. So these are all U.S. prices, so I'm not sure what's in Canada, Europe, or Asia, etc. So talk to your reps there about it. So the total cost for us per case is $105. In my opinion, all right, yeah, it's a little bit more than what my calculations for $30 worth for our practice, but you know what? It's going to save me time. And for me, that extra expense totally is worth it. So I think the cost is really, it's cost not prohibitive in my opinion for what you're getting.
Is arch form width something we control in setting up our program? In other words, can we set up the specific arch forms?
You can in SureSmile if you do brackets and wires. But I do not believe, because this is just an indirect bonding system, I do not believe that you can do this in SureSmile's indirect bonding system because you're not ordering any wires off the system. Now, if you become a bracket and wires guy in combination, I was actually just talking to Steve Peterson, who practices out of Madison just last week, and he's actually when he's doing these indirect bonding setups, he's actually setting up a plan as well, and he is inserting an actual SureSmile wire that's based off that final plan. So that's with the customized Artform. So that's the robot bending the wire, and he's inserting that 4 weeks after the indirect bonding case has been ordered. So he schedules 4 weeks out between the intro scan and when the actual full bonding starts, and that's how he's doing it. So there's a little bit of a time issue there because we typically try and schedule out 15 days between our intraoral scan and then the actual full bonding with SureSmile's indirect bonding system. All right, and that gives us time to have SureSmile clean up the intraoral scan and segment, which is they guarantee back in 1 to 2 days. Us to do the plan. Right now it's just me, but in the future it's going to be our digital lab techs. And then I think they guarantee 5 days that they'll have the 3D, the indirect bonding tray 3D printed, and then you got to account for shipping. And sometimes we live in Wisconsin, Green Bay, Wisconsin, the frozen tundra. So there can be disruptions there with snowstorms and stuff like that. So we just schedule 15 days just to be certain.
All right. We do have other questions, but we're coming to the end of our time. So we promise that we are going to answer your questions via email privately after the webinar is over. But in closing, I invite our viewers to visit www.elemetrix.com for more information, or call 888-672-6387. That's 888-672-6387. This information will also appear in your control panel chat box. Thank you for attending this webinar. Thank you, Dr. Lin, for a wonderful, informative webinar. And we will send you, following the webinar, we will send our attendees a recording of this presentation. Thank you.
Thank you very much, everybody. All right, have a great weekend.